record it. And so I don't know, Savannah, if you have any questions or anything specific that you would like to ask the seniors, you're welcome to.
Yeah, I'm really just here to like hear what they say, how the process has been for them.
Right. Okay. So I don't know, like I'm gonna start with one question, and then I'll just let y'all kind of take it, and
Okay.
then I've got another one for Jesse. But the one question I had is, how prepared are you with what all you've learned in our program? Like when you go in, I hear a lot of times that no matter what your program is, when you get in the real world, it's like a totally different world. So I'm just curious if you feel prepared or if you feel like there's so much more out there than what you've learned. And it's just anybody; it doesn't matter who.
Well, I guess I'll start. So my first rotation, I was at a pediatrics clinic, um, and now I'm at an outpatient ortho clinic. So honestly, for the peds rotation, I was prepared, but like in knowledge, but not in kind of skills with children, because it's when you guys take the peds class, like you'll understand because you're doing a lot of the things on your peers who are not children, or you're doing a lot of everything on a doll. So it's very, very different. So like I had the skills, I mean, I had the knowledge of kind of what to do and like what, how to, what these muscles did and whatever. But it's very, very different because with kids, you don't look at them and say, "Hey, here's a TheraBand. Like, you're gonna do 15 of these exercises." They're gonna look at you and be like, "I don't like," and then they're just gonna run off. Like, they're not doing that.
Right.
So you have to be very, very creative, and also you're doing things that you don't think about. So like a lot of our kiddos, and what we kind of learned in our PEDS class was mainly like cerebral palsy, Down syndrome. What were the other ones, guys? I mean, that was two of like the biggest ones. Um, and I think I only
Can't
saw,
even remember, to be honest. Sorry.
yeah, I
Yes.
only saw two kids with cerebral palsy and then like one or two with Down syndrome. Every other kid that we had was like, didn't really have really neurological issues. They just had like coordination issues kind of thing, or they were just delayed in some of their skills. So you're doing things like, okay, yeah, we want to work on, they're a toe walker, so we need to work on dorsiflexion. Well, you can't just do dorsiflexion, so you're walking like a duck and you're propelling a scooter with your feet and you're doing things like that. So with the peds part of it, I mean, I felt kind of prepared, but not like I could have been more, I felt like. But with this outpatient, I feel like I'm very prepared with the knowledge that we've been given. And also what's benefited me is like having the stuff to look back on and think about, and just talking to my peers about like, this is what I'm seeing, this is what I'm doing, like what, do you see this, what do y'all do differently, and just kind of bouncing ideas off of each other. So with the adult world, I feel like I was prepared, but with the
Right.
peds world, I feel like, and that was my first clinical, so first time ever seeing a patient and it's a child.
Yeah,
That
that
was a
I
little,
could see where that would be kind of nerve wracking and totally understand. And I guess like you have to kind of think how you deal with maybe I don't know, cousins and whatever little kids in the family or something. I would
mm-hmm.
imagine. So, what
Yeah.
about like you, Josh? What setting are you in, and how do you feel?
I mean, I feel really good now. I mean, even my first day, it was a big confidence boost just because of the place I was at. It's just a bunch of good people, a bunch of good PTs, PTAs. So I'm an acute and inpatient. So I'm with a guy who floats between both.
Uh huh.
Um, he mainly does acute, but if they need help in inpatient, he'll step in and do a patient or two a day, whatever they need. Um, but as far as being prepared, yeah, man, For the most part, definitely outpatient and inpatient, because a lot of that stuff is more like Therex, walking people around, just
Right.
getting them moving basically.
Right.
And if you like my advice, if there's something you want to focus on, as far as being prepared and impressing your CI and stuff, it's just being safe, keeping your patient safe. That's the biggest thing. Like, it doesn't, they will care more about that than how good you are with anything else. If you keep your patient safe, and that's your first priority,
Are you
right?
talking about like maybe trips and falls or that type of?
Exactly. Because that's the thing is like, my CI has told me multiple times, and I'm glad he has, like, some of these people are really high level, like they'll walk 500 feet or something, but they can also, like that,
Yeah.
fall down, get, knee buckle and just go down, so you got to be real careful. You gotta, just because they're doing well, especially people with like CVAs and, you know, just the higher stuff, they could be progressing great, man, but you just don't know. You don't know. They could literally drop out on you. So
Right.
you always got to play safe. You always got to have plan B and just be ready for anything. And if you walk in that door day one, knowing you can keep your patient safe, all that other stuff's going to come much easier, because you won't have to worry about that. You'll be prepared to keep them safe, and you can worry about learning all this other stuff just from them, and that's what I did. Like, I knew I could keep patients safe, and that let me just kind of learn and soak up all I could from my CI every day.
Right. That's good. And I remember, and I know Savannah, like your first semester, so y'all are going to be doing like bed mobility and bed transfers, stuff like that. And I remember we were doing that, like we were talking earlier about how Miss Weatherhead would grill you and catch you on things. And I know, like with the transfers and different things, like you think it's a simple thing, and there's so many little things here or there that's going on at once. And it's like I'm concentrating on one thing, and she's like, "Well, did you notice you didn't lock your legs in back behind their knees, and like you could have them buckled just like you were saying." So I get, like, I mean, that's good advice, I think.
And I've learned just as much about safety as I have when I take it in. Like I've gotten real good about knee guarding with my knees, keeping them. That was one of his big pet peeves is blocking their knees with yours, and just keeping them extended in case they do go down, and just moves with your knees, so you can, if they're sitting edge of bed but you need to turn them a little bit, you use your knees and kind of grab the pad and swing them around. Like, it's just little things like that they don't really teach you in class, but are safety, plus a little bag of tricks stuff,
Right. Right.
that you pick up in the real world. And that's the kind of stuff you'll be getting, is that real world little bag of tricks,
Right.
along with staying safe. So
When you transfer someone and it's not the greatest transfer, because not that you didn't keep them safe, but it's like there was one little thing that you could have done different that would have made it a little easier for you. You'll never not remember to do that again.
Right.
You'll always remember, okay, I need to pull my wheelchair a little bit closer to the table, or, like I need to lower my table just a little bit more if they're on a high-low table, or like things like that. Like when you transfer someone and it's hard on you, and then you're like, wow, I definitely could have done that easier by doing this, you'll never not do that again.
So my example, personal example outside of PTA, was I was a phlebotomist for a year at a plasma center. And literally my second stick that I ever did on anybody at there, I forgot to clamp off my tube. So when I stuck them, blood was just like everywhere. I mean, it looked like a crime scene. I clamped it off, and like luckily it was an older patient or someone that donated a lot. So they were like pretty chill about it. And everybody else around, I was like freaking out inside, like shaking. And they were all laughing. They were like, just clean it up, but I promise you'll never do it again. And I've never did. Like you said, once you do it one time, it's like every time, just don't forget that. What about you, Jennifer? How do you feel, like what kind of setting are you in, and you're?
I'm in outpatient, and I'm actually at the same clinic for my second rotation because my original one got canceled. So I've been there for a good bit, but I felt like well prepared going into it, because it is basically all Therax. So if you're good with Therax, you can think of exercises, how to progress it. That's great. And I think it's really cool too, because yeah, if you know a lot of things, you also don't know a lot of things too. So like you're always learning as well, especially from the PTs, and they'll always like pull you aside and like make you think more about it. So I feel well prepared, but there's always like room for growing too. So it's not like, I don't know, like I can think of everything off the top of my head. Like you learn so much more out in the clinic too that you don't learn in the classroom.
Right.
And I will say that time management is a huge thing. It is so huge. So we will get like double or triple booked for an hour. So it's like time management and then also making sure you have a plan kind of thought out. So that's been probably one of like my biggest obstacles, because you can't really learn that in the classroom. You just
Right.
got to figure it out. But I feel like I've been well prepared for it. So I have no
Awesome.
complaints with that.
Awesome. So how many patients do you probably see a day? Do you work like in 8 hours, or is it just until you get X amount of patients done?
No, so we work like 9-hour days. So like 7 to 4 or 10 to 7. And then I ideally see at least one patient an hour, sometimes 2. So I'm looking at about like 8 to 10 patients a day.
Okay.
But like they gradually put you into that. So like at first, like my first couple days. So another thing too was that my CI already had a student. So, and then there was another PT student there. So for me, I think I was lucky because I kind of like gradually got into it. They didn't throw me in because there was already another student there and she had to fit like her quota like per day. So it was cool to observe like how a student was doing stuff and then
Right.
how my CI, who was a PTA, and then like the PT do it. So for me, they didn't throw me in, and I like that a lot because the first day is always like so nerve wracking. But
Yeah.
yeah, it's pretty good.
Yeah, I honestly still, like right now, I get nervous about it sometimes thinking, and that was kind of like the whole deal about, talking with all of y'all. But what about you, Kelsey? How did you feel, and like what setting are you in right now, or have you been in?
My first rotation, I was in acute care at Northeast in Concord. And I shadowed a PT and a PTA, just kind of depend on the day.
Uh-huh.
Both were completely different. But kind of feeling prepared. I don't know. Like I hated it the first week. For me, it was just like such a shock because like in school, like you learn, I feel like you learn mostly outpatient scenario stuff. To when you go into acute care, like you're doing good if you get these patients out of bed to stand. Like you might do 2 sit to stands and they're worn out and you put them back into bed and your treatment session is 10 minutes long and
Right.
that's it. To where now I'm in an outpatient setting and we work 11-hour days and like we see anywhere from 2 to 4 patients every hour. So it's just like completely different. I wish that I would have went outpatient right out of school. I would have felt more prepared, like to use all of that hands-on stuff that we learned in Therex and used
Right.
it fresh out of school. I feel like I would have been better at my outpatient setting now because I don't have that great of a CI. So I kind of figure things out as I go. But then I ended up loving acute care. Like I ended up, to me, I feel like using my EMT background knowledge more than like my PTA background knowledge that we learned. And it's just things changed so rapidly. Like on my last day, we had to call a code on someone. There's just so much that goes into hospital work, but it
Yeah.
always keeps you on your toes and I loved it.
So I did my last shadowing, I did at Northeast there. And so it was kind of eye-opening to a degree for me. Like we went into some of the acute care and you've got like literally 20 different leads and just all kinds of stuff all over his patient. And we walk in, I'm thinking, okay, I guess they got to get a nurse or something. And the girl's like, here, you hold these. And she's just pulling everything off. And I was like, oh my gosh, like, okay. And then I was sitting there thinking, how are we going to hook this back up? But, she just said, you got to pay attention to what you're doing and, and all that. So, what about like all of y'all, as far as like your CIs at your place? Have they been pretty cool? Or, I mean, kind of heard some of what y'all were saying, but.
Really quick, I will piggyback off of Kelsey though, but like for me, because I have to go into like acute or inpatient after this, and then now that I have 2 rotations, like in outpatient, I feel like I'm gonna be so out of it whenever I get to the hospital setting, because I'm gonna be like, I can't remember any of this because it was forever ago and I didn't use an outpatient. So I don't know. So I feel like our roles are kind of switched, Kelsey.
I got you though. You let me know. I will prepare you. Josh and I will prepare you.
I feel
For
like,
Please do,
inpatient.
because I'm gonna be way in over my head.
yeah, I understand that too. So kind of to piggyback off of what everyone said. So what Josh was talking about with safety is like, that is a big thing. That is how you impress your CI. But also, so what I learned with my pediatric clinical is, yes, the most important thing is keeping the patient safe, but the second most important thing is keeping yourself safe. So you need to prepare yourself to have good body mechanics. You need to prepare yourself of where you need to be with the patient and what activity ever you're doing. Because that was one big thing that I kind of got counted off on at my peds rotation, was that I didn't have the greatest body mechanics, and my CI was like, yeah, right now, like, you're totally fine. It doesn't matter. But like 5 years down the road, like, you're gonna not be able to do this because your back's gonna be killing you every patient that you have, and you can't do this. So that's number one, is like, just while you're going through this and continuing to practice throughout the program before you get to your clinicals, practice with things that you're not comfortable with. Like, don't just look and say, oh, this person's light, so let me go transfer them because that's easy, because that's 9 times out of 10, that's not who you're going to be working with.
Right.
So don't take the easy road out, and make sure that you have the proper body mechanics and the proper safetyness for yourself, so that way you're prepared. Piggybacking off of what Jenny was talking about with the patients, so because I have a PT and we do evals, you have to have an hour for an eval. So like today, I think we only had one eval, so we saw like 9 or 10 patients today. But the PTAs in my clinic, my CI doesn't work on Tuesdays, so I follow a PTA on Tuesday, and we see anywhere from 12 to 16 patients a day.
Wow.
Because it is every half hour. Sometimes you're getting 2 in, like, you might have 1 at 8:30, 2 at 9, 1 at 9:30, 2 at 10. And so like, it's just like, so the time management thing is for real. Like, that's not something that you can really work on, because they're not gonna put you in a thing where you have 2
Right.
patients. But that's just something to be prepared for. And then also, something that has not been brought up yet, documentation.
Yeah.
So what my best advice that I could give you with documentation is, when Miss Prado looks at you and says, okay, take this home and write a soap note and bring it back tomorrow for me to check, or whoever does that, say, okay, but time yourself, give yourself 10-15 minutes to write an entire soap note, and see what you can get done in 10-15 minutes, and then start from there. And then the next time yourself again, and just keep timing yourself until you can get an entire soap note done in 10 to 15 minutes. Because at the peds clinic, so with pediatrics, you treat for at least 53 minutes. Well, at mine you did, because we had 4, you had to bill for 4 units. You only see 1 patient an hour because it's peds. So you're seeing 1 patient an hour, you have 53 minutes. So if, let's just say you start at 9 o'clock, by 9:53 you have to be done. And then from 9:53 you have to get your patient back to their parent or to their next therapy session, pee if you need to go to the bathroom, and then also you have to write an entire note before your next child comes in at 10.
In 7 minutes.
Yes, to do everything. And then at my peds clinic, you got paid by the patient. So like, if your patient didn't show, you weren't getting paid for a whole hour. So
Right.
she did not book herself lunch because she was like, why am I going to sit down for 30 minutes and not get paid? Like that, I'm not doing that. So in those 7 minutes around lunchtime, you had to pee, get your patient out to the next person, document, and eat your lunch all in 7 minutes. And then be ready to go to the car and get your next patient or wait for them to be dropped off in the gym by the next therapy or whatever.
That's
So
ridiculous.
yeah, dude, it was insane.
That shouldn't be a thing.
I
Oh,
will say too, like outpatient, you can always like work on your step note as you're like doing an exercise. But with like peds, nah, you're 100% with them the whole time. So it's like
And
totally different.
that was a big thing for me to get adjusted with because with peds, even our higher level kids that I'm literally just kind of standing around or I'm just kind of saying, okay, we're gonna, jump down from this, and then we're gonna jump this far, and then you're gonna jump over this, and then we're gonna get the puzzle piece, and we're gonna do it all the way back. Those kids, you're still hands on. You're still walking with them every time that they do something. You're teaching them how to ride a bike, and you're on a stool behind them because they can only pedal half a cycle. So you're hands on with every single patient. When you get into outpatient, it's like, okay, well, here you go. Like, do this. And then you stand there, you're like, do 15 of these. And then you stand there. So
Yeah.
that was a very, very big adjustment that I had to make my first week in because I was like, I'm doing nothing. Like, I feel like I'm doing it coming from the peds clinic when I'm hands on for 8 of the 9 kids that we saw today because the only one I couldn't be hands on for was the infant. And all the rest of them, I'm doing the whole treatment. So that's a big adjustment. But documentation time, just like even if Miss Prado or any of them says this is for homework, go home and do it over tonight and bring it back tomorrow. Try to get in the habit of like timing yourself and giving yourself a time limit, and maybe not even start out with 15 minutes. Maybe start out with like giving yourself 30 minutes to do it, and then decrease it
Work
from
it
there.
down.
But like work on getting your notes done like in a timely manner, because I know like my CI now at my outpatient clinic, like by the time 5:15 rolls around, like and our patient leaves at 5, she's ready to go. So like you gotta have your stuff kind of down because your CI's not gonna, if they've been there all day, they're not gonna want to really
Right.
stay.
So a question on the documentation. Do you take notes during, like, how do you remember what's going on in that amount of time?
I've gotten better at that. I used to not do anything and be able to remember most of it, but now I'll write down oxygen sats and heart rate, and I'll get the timeouts. Sometimes I forget the time in a lot because I'm just ready to go in there and talk to them and get it over with. So I kind of have to like, guesstimate how long I've been in there sometimes, but I'm getting really good at doing the timeouts now.
So time in, time out means the time that you started with a patient, and time out
Yeah.
when you finished with a patient.
I know that's kind of important, but like, you don't have to be down to the exact minute. Like I know I walked in this patient's room within 2 or 3 minutes of the time I know how long I've spent with them. You know what I mean? So if I've got the time out, I feel pretty good about it. And that's just because, man, I'm ready to get in there and help somebody. Like, I forget to look at the clock, and like I'm in there and I'm trying to motivate them because a lot of these patients, they really don't want to do anything, man. And there's a lot of people in and out of their room that just don't care. They're just in there to get done what they want to get done and get out. So sometimes you'll be spending 10 minutes just trying to convince people that you're there to help them, man, and you actually give a crap about them, and you're not just another, machine in their
Right.
robot just to
Yeah.
do what you need to do to get out of there. So I don't know. And yeah, and in documentation, so I would work on like, so another advice for me would be like have some key phrases. Like I kind of stole this one from my CI where he'll do a whole assessment and he'll say, they're doing good at this, doing good at that, or whatever. And the last sentence will be like, patient will continue to benefit from skilled PT to improve functional mobility and activity tolerance, which is endurance. But endurance can like be a bad thing to say, that he was telling me, because like if we're working on somebody's endurance, they might be better off, they might sound better off than, maybe they don't need PT if we're just working on endurance, you know what I mean? So anyway, so activity tolerance and functional mobility to, basically get them out of there and make them functionally independent. And that's kind of like the wrap up sentence. It's like, hey, these guys are doing all right. They still need a little help, but you know, skilled PT can get them there. You know, and work
Our
on phrases like
phrase,
that.
yeah, our phrase at Northeast was like, patient will continue to benefit from skilled PT to optimize return of prior level of function. So, I mean, you have those certain phrases that you pick up, that you
Yeah.
use. And like time in, time out is most crucial in the hospital setting, because you don't have a set schedule. Like you're seeing this patient from 9 to 10, and you're seeing the next one from 10 to 11. Like you go see one patient and they may say, come back later.
Yeah.
So like you have to know when you go into patients' rooms and when you leave.
Right.
So
I remember when I shadowed there, we had, because I was there for 2 days, we had quite a bit of patients. We would go in and they had just taken their medication, so they were loopy. So they said, okay, we've got to come back this afternoon at 2. You have to go catch the nurse and find out when are they going to be due for their meds again, and give me that time, give me 15 minutes or whatever during that time for. So I do remember, you know, that, and we were constantly. We also, like Josh said, we had one patient. We were going, and she was like, I can tell you right now, we're gonna have to find such and such tech who is the only person that can talk this guy into doing anything. And then he still refused. And like you said, eventually after maybe 5 or 6 minutes, she said, we don't have time to wait around. We got to go to the next patient. So we'll just, you know, try and come back tomorrow or something like that. So a question that Jesse had, kind of back on to where I was talking about taking notes for documentation, is can you use cheat sheets for, you know, anything, I guess, you know,
Yeah.
for.
I mean, there's
Yeah.
no, yeah, I don't see why not. If you need to write notes down to help you remember stuff or
So let me.
whatever, yeah.
So for my peds clinic, I literally, because like our schedule was the same every week, every day. Like there wasn't this how like an outpatient and in the hospital, like it can just be like, oh, we're gonna see, you know, blah blah blah. No, like every Monday at 8:30, you saw little so and so, and then he would be back on Wednesday at 8:30. Like that's how it went every single week. And so I would know who I was going to be treating the next day. And so I literally had a Word document, and it's deleted now, but I had a Word document, and I would have all of my patients' names on it of who I was treating, and I would like, or for the whole week, I would have who I treated and who she treated, and I would go through and I would see what we did last treatment, and I would literally write down like a list of like, okay, so last time they were jumping down from 26 inches, so this time we're gonna see how well they can do for a couple, and then we're gonna bump it up to 27. And then we were jumping forward this, and I would highlight who I saw that day, and I had a list of like what their goals were, what they, so that way I wasn't constantly having to check back in the charts and go back. So I had a cheat sheet like that. But then also at the outpatient place that I'm at right now, so y'all, we do flow sheets. And I never thought that we would do flow sheets, but we do handwritten flow sheets. And so I'm like, dang, Miss Weatherhead, I really should have like paid attention more to that. Like, God. Um, and so literally, I mean, you just look back and you're just like, okay, like, well, this is what we've been doing. Like, maybe we need to up that, or you know what, like, let's change it to this, or you've done 30 reps of this with a 1 pound weight. Like, let's move on to the next thing. And then everything that we print out, like all their HEPs and everything goes in that chart. So everything is right there. So
Mhm.
like, don't think also that you're going to be out there and you're just going to be high and dry and left on what's in your brain. Like, and a lot of times your CIs are really cool, and like my CI, so like I was how she'll do an eval, and like she'll just kind of throw me in there and be like, well, what should we do now that you kind of have the information? And I'll like say something, and if it's wrong, she's super awesome, and she won't like kind of make me feel bad about it. She'll just be like, that's a little advanced, or like, we don't want to do that because of this reason. And I'll be like, oh, okay, that makes sense. And then she'll direct me in the right reason. So, like, also don't think that you have to go in there knowing absolutely everything and memorizing everything from every class to show off. Like, just go in there, be yourself, know what you know. And when they seriously, when they ask you a question and you really don't know the answer, just say, I'm just not totally sure. Maybe I miss, you know, like, I'm just not totally sure. And they will be like, okay, that's fine. Like, and they'll usually talk through it with you and just like teach you about it.
Yeah. So does
So,
that happen a lot in front of patients or more like when you're prepping for the, the
um,
I think they'll help you like critically think in front of patients. They'll like
Mhm.
ask like, what do you think like this means, or like based off of like what the patient said, like what do you think we should do?
Mhm.
And then they'll like let you think it out, help you with that thought process. And most of the time, like patients don't care because they want to hear what's going on. They kind of want to understand too. Like it helps them understand. So, and they're actually, I was pretty nervous about like seeing patients and saying like, I'm a student, whatever. And then a lot of people are just like, awesome, like cool. Like they don't care at all.
yeah.
So, but then also with like my documentation, like going off of Alicia. So for ours, we have like an attachment folder and it has like protocols, like everything that the MD has sent over, like all the things that you would need to look back on it. And then you also have like your previous notes. So like your previous, like the initial eval, your re-evals, your daily notes that they've been in for. So you can look back and see like what they did in the last treatment session and what their goals are based on what they found during that treatment session. And so then also on your screen for the treatment session, it'll already have like exercises that they've already done. So you can click, okay, we can do this again, whatever. It's also like a flow thing. So if
Right.
you want to add in like, I don't know, if you want to add in an exercise, it's just like drop down after drop down after drop down. So it kind of like leads you there. So it's actually pretty easy.
Uh-huh.
Kind of a lot to like look at first, but it kind of guides you into what you want to do. So but like every documentation system is different, but that was just mine at my clinic.
Right.
Let me say something about the CI before we move on, because I had a funny story that happened recently. So my CI is pretty cool, man. He's been working about 5 years or so he's pretty fresh, which is cool, which I like. Um, and I was seeing like a high level patient. And I can go see patients on my own or whatever. He'll usually find something to do, or he'll just hang out and kind of listen to what's going on. But I was seeing a really high level patient, and he was like, just go in there and do it, man. Just go in there and do what you normally do. Think you know what's right to do. Just go do it. And he's like, honestly, the patient doesn't know if you don't know what you're doing. Like they don't know. As long as you don't tell them that you don't know what you're doing, they don't know, man. Like, so like as long as you're not like literally verbally saying, you did the wrong thing, they don't know. And fake it till you make it's kind of a real deal. And like I'm not saying go in there and just totally come up with some crap that is, have no idea whether it's going to help or not. But
Right.
stick to your basics if you're not sure. And if you feel unsure about something, then you probably shouldn't do it. And
That's good advice.
or like if you start manual muscle testing the right leg and they just had a left knee replacement and that's what you're supposed to be manual muscle testing, just being like, just play it off and be like, yeah, I just gotta compare the two
Yeah.
legs. So like just like totally 100% like Josh was saying, like don't go in there and just totally like wing it and like, but also like go in there and just kind of, if you mess up, don't say, "Oh my God, I just messed up." Just be like, just play it off and just like go with the next thing and just be like,
move
"Oh,
on to the
now
next.
I want to see you do this." And that's really what you wanted to see him do in the first place. And you
Yeah.
just, um, but piggybacking off of what Jenny said, I feel like, and y'all can, Josh, y'all can kind of like back me up on this if this is how you felt. I feel like going through this program, they kind of like terrified me of like, you make sure that they know that you're a student and they have the right to say no, you're not treating me and blah blah. Every single patient that I have seen so far is like, oh my gosh, that's so awesome. You're gonna be such a great PTA. Like,
Yeah.
where do you go to school? What's your life? Like, where do you live? How's your life? Like, what do you do? But like, I mean, like they do not care that you were a student. They completely understand. I don't know how many times a day I hear like, this is so amazing, and I'll be like, I'll talk out loud and Anna will talk back to me and like we'll just be, and I'll be like, I'm so sorry, like, or whatever. And they'll be like, no, like everybody's got to learn, like this is what you got to do. But like they make you, I feel like in the program, and I get it because that could be a lawsuit on you, that could be a lawsuit on, like I do understand it, but they kind of make you feel like, oh my God, people are just gonna hate students and gonna say no. Every single person I've
Gotcha.
had, like I go out to the lobby and I get them and they're like, oh, am I not seeing so and so today? And I'm like, no, like you are. I'm just like, I'm just starting you and doing your treatment. And they're like, oh, cool, okay, awesome. Like I have this one lady who doesn't like my CI, so she prays that she sees me that I do her treatment rather than my CI. So like she like just because you're a student, like yes, they need to know, but go in there, be confident, and most of the time, like your patients are gonna just like that. Like Josh said, like they don't know what you're doing. They have no clue. And so like if you go in there and you do what you know to do and you act confident, you're gonna be fine.
Yeah,
Yeah.
and I just like her. Uh, I had two old ladies that wouldn't work with anybody else but me, like, and that felt great. And like,
Yeah.
you got a PT over here that's got 20 years experience. You got a PT over here with 10 years, and then I got Jeremy my CI with 5. And just because I talked to this lady and treated her like a person, and was nice to her and cared about her and helped her get better, she didn't want to have anything else to do with anybody else. It was just me. Like I was an inpatient for like a whole week when I had mostly been doing acute just because this old lady liked me, and it happened twice, and it just felt good. And it felt good to hear him tell Miss Martin that too. He was
Yeah.
on one of the Zoom calls. He was like, these little ladies, they didn't want him to have anything else to do with anybody else. They just wanted
That's
Josh.
awesome.
And I was like, man, that's great. And I know I'm not the greatest PT. I know I'm not as good as these guys, but I just took the time to get to know somebody and help them out as much as I could and do what, work within my skill set, even though it's not as big as theirs.
Right.
So I still got the job done.
I know my
Yeah,
wife's.
I will say that like patient rapport is huge. Like even
Yeah.
if you're just like asking about like how are their grandbabies, like what are they up to, just like anything. Like I have one patient, and he was like, Jennifer, did you have breakfast this morning? Did you drink your coffee? I'll get you some coffee. So he like offers to buy me food like all the time, and he'll only work with me too. So it's so funny. It's like having those small conversations make a huge difference in your treatment session. So it's not like they're just there to work. They're just there to like be a machine, go through everything. But like just treating them like a real human being goes a long way.
Right. You found that too, Kelsey? Have you?
Yes, for the most part. We have a few that are not that they like don't want to work with me. They're just kind of picky, and I'm like, that's fine because I really don't want to work with you either. I just save the headache. So, but yeah, I mean, for the most part, I mean, I don't even introduce myself to anyone, honestly. Like we see the same patients over and over. When I sit in evals, I introduce myself, but it's not like, hey, do you want to work with me today? It's like I go out there, come on, you're mine today. And
Right.
because I get a caseload every day. Like I see 1 or 2 patients every hour along with like everyone else in the clinic. I say everyone else, it's only a PT and a PTA and then me. So it's not like it's some big ordeal, but it's like they don't really get a choice. It's like, you're mine. It's okay.
Right.
And I will say too, you have to be like, yeah, you can have great patients that don't care and stuff, but you also have patients that are just a pain to work with. Like they don't want to be there. They make it known. They'll like throw a temper tantrum the whole time. They'll cry on you to get out of it. Like it's ridiculous. We have one patient, we discharged her and she came back for work conditioning. So now she's not there for 1 hour. She's there 3 times a week for 3 hours long. And she makes it known that she does not want to be there. And she's just like super nosy and bossy. Like when you're working with patients, like, what are you doing? You pinching them? And it's just, you got to roll with the punches sometimes.
Right.
Got to learn to like brush it off your shoulder. And like the good patients make it so worth it. I will say that.
Yeah, it's definitely not all sunshines and rainbows for sure, man.
Right.
There's some tough ones. I know this one lady, we had to work with her 3 times before I got her trust. Like she was just so scared of falling and just didn't trust anybody. And like I said, there's a lot of people that don't talk to them and treat them like people. So it took a long time to win her trust, and she was doing a lot better than she presented just because she didn't feel safe and didn't trust anybody. So it
Right.
took, she was acting like a mod or max assist when she was really a min because she didn't trust her, and it was, and that kind of stuff will happen too. And
So
I don't know.
with the kiddos, it's literally like two opposite ends of the spectrum. So we 90% of the kids that we saw, because I was new, they gave their all. They loved me. They didn't want anything to do with Angie. They only wanted me to treat them like. And then we had certain ones that this little guy that we had doesn't hardly ever make any movement on his own, and he knew that I wasn't Angie, and he literally pushed away from me. Like, he's never done that to anyone. He's never like so much put forth effort, and he pushed away from me. And Angie was like, whoa, like he's never done that to anyone. And then we had this other little girl who she does not do well with new people, and she's nonverbal. And so Angie asked her one time, she said, is it okay if Alicia walks with you? Because we were walking down the hallway. And she was walking with her walker, and she literally turned around and looked at me and then looked at Angie and said, and Angie was like, well, I guess I have to respect her decision, because she like actually answered in like an actual manner. Like, that made sense. Like, she knew exactly what I was asking, and she said no. But with adults, like they're super chill. Going off of what Josh said, I have to say this. So my CI, my second week there was out all week. And so I hung out with the PTs, PTAs, everybody else in the clinic, because they're so cool during this rotation. And that at the end of that week was our Zoom meeting with Miss Martin. And so Anna's like, she starts the Zoom meeting and she asks Miss Martin, she's like, like, do you need to speak to Alicia? Like, we're still finishing up with our patient. Do you need to speak to her? Do you need to speak to me? And Miss Martin was like, well, I mean, it doesn't really matter. Like, can Alicia like do the treatment with the patient? And Anna was like, oh yeah, she's got this. So like second weekend, I was like, and she says that, I'm like, and this is our most complex patient. So that made me feel great. Then the patient doesn't like anyone. He hates everybody. If Anna's not there, he doesn't come to therapy, because he doesn't do well with anybody. And he yells at Anna, and he's yelling to Miss Martin. He's like, tell her about me. He's like, tell her how he calls me Bird. He said, tell her how good Bird's doing with me. And then Anna starts telling Miss Martin about it. And he goes, Bird, I got you back, like that, and like gives me a fist bump. And I was like, that made my heart so happy.
Yeah.
And then Anna's like walking around. She went somewhere, and all the other PTs and PTAs in the clinic knew that she was on the phone, like on the Zoom meeting with Miss Martin, and they all literally like stopped her and was like hyping me up to Miss Martin, and was like, she's doing so great, like blah blah blah. And so when you go in there and you show your stuff and you like know what you're talking about, and you just kind of, even if literally it's putting forth the effort of like your PT or your CI says something like, we're going to do heat first, and you're like, I'm gonna get the hot pack, and you just go get it, showing that initiative, they're going to love you, and they're going to be more willing to teach you and do more things with you, or letting you do more things, rather than if you just kind of like stand back, stand off, don't really say
Right.
much. Like, if you go in there and you show that you want to be there, it's
Right.
gonna look so great, and they're gonna love you.
Good advice.
Yeah.
So I was thinking right before you started talking, another question to ask, and you kind of mentioned the hot pack. So how much of the modalities do you use that we've gone through? Do you use those? I know we talked a lot. All of you said Therex. Like, so how much of the modalities do you use?
0 for me. Outpatient guys,
Yeah.
go ahead and talk.
Besides ice and heat, we do nothing. It's all manual work for us.
We do lots. We do E-stim. We do NMES. So like getting the contraction with it.
And that's what we're doing right now in class.
We do NIMS. We do regular E-stim. So just like IFC.
Yeah, IFC and pre-mod. Yeah,
Whatever it's called.
interferential IFC.
Well, okay. So literally you learn all this. We do, you cross one patch and you cross the other. That's all we got. That's all you do. So we
I feel like
do
they don't even know. They don't even know that stuff anymore. Just so you know, they don't know it. Okay,
we do
like they
those.
don't.
We do cervical traction a lot. We do, I haven't seen lumbar traction, but we do cervical traction.
Do you do those mechanical, not manual?
We do both. We
Okay.
do manual, and then we hook them up to a machine. Also, fun fact, did y'all know that you could get a at-home cervical traction machine? Because I didn't. And then one of our patients the other day was like, I have one of these at home. And I was like, wait a minute, hold up. Yeah, super cool. So we do traction, we do ultrasound on just about every patient that comes into the clinic.
Really?
What else we do? I don't know. I can't remember if we learned about it, but we do what's called H-wave. Do y'all remember H-wave or no?
That doesn't sound familiar.
It doesn't sound familiar to me.
So it's basically it helps with your lymphatic system as well. So we do it on a lot of our patients that have swelling. We have a flutotherapy machine. None of my patients have done flutotherapy, but we do it like they do it at the clinic. What else? There's another modality that we do a lot. Ice and heat. And Ionto.
Okay.
Y'all haven't. I don't know if you've learned about if y'all.
We've talked about it. That, like, say we're like literally right in the middle of. We had exam yesterday. I mean Tuesday, our first exam, and it was all NIMS, all ESTEM, all that stuff. Kelsey, what about y'all? Do y'all use a lot of modalities?
We use eSTEM, NMES. We have a Game Ready device we use.
Yeah.
We don't have ultrasound. I think that's it.
Do any of you use do soft tissue mobilization
every day? So my my PT is a certified manual therapist. So basically, like the first 30 minutes of every treatment for me is soft tissue and joint mobs.
Okay.
So, and then he does dry needling too. So he'll dry needle quite a few patients. And we also use like a Graston tool. I don't know if you've ever heard of it, but we use a lot of it. Graston, Graston. It's just like it's basically just a fancy word for a piece of metal that you rub over their skin to realign collagen fibers.
Okay.
It's
I think I have
instrument assisted soft tissue mobilization, basically.
We do that a lot too.
Yeah.
But yeah, your hands definitely get a lot stronger. So.
And with our travel PT, he just brought in a Theragun, and now every PT and PTA in the clinic is obsessed and has bought one themselves, and they just ordered one for the clinic. So that is about to make my life a whole lot easier, because what you can get done in 10 to 15 minutes with your hands, you can get done with a Theragun in about 45 seconds. So we love it. I'm actually about to order one myself because it's great.
Jesse's got one. She bought one, and I know she sings praises for it too.
It's awesome.
So let me do this real quick. First, Savannah, I know I've been doing all the talking and questions. I don't know if you have any questions that you've thought about while we were on here. Is there anything that you'd like to add or ask?
They pretty much answered a bunch of the ones that I had. It's pretty early for me.
I know. You know, Savannah, when I did my shadowing, like all these different PTs and PTAs were asking me, well, what do you want? What kind of questions do you have for me? I'm like, I don't have a clue. Like, I don't even know what kind of questions to ask. So I get it. So, and I know a lot of what you've heard them say tonight might be like, okay, what in the world's that all about? But trust me, when you start getting into like the rest of this semester, next semester, you're going to be like, oh yeah, that's what they were talking about that
yeah
night. I've done the same thing with like hearing, you know, from my shadow time and stuff like that. So all right, well, let me do this because like we've been on here almost an hour and I really don't want to take up like all of y'all's time. Give me maybe all of you one at a time, just give me maybe 1 minute of any kind of advice you want to give or anything that you want to add. And if you don't have anything, that's fine. I know y'all have all like gave us like a wealth of knowledge so far.
I can add one real quick, just
Okay.
and I'm still probably a hypocrite on this one, is don't go in there feeling like you got to know everything. You know, you're there to learn. Like, if you got a good CI, they're not gonna expect you to come in there and be a, you know, great PTA. They're gonna know that this is new and you're just starting out and you're still learning things, even if you got a great foundation. You know, don't be so worried and hard on yourself that you can't go in there and learn. Because if you do that, you're not helping yourself at all. You're not going to learn anything. So just know that, you don't have to be great and you don't have to know everything. And if they ask you a question, you don't have to know the answer. There's a lot of questions I'll ask myself. Yeah, he don't know the answer. We'll have to look it up.
Yeah.
Like they don't know everything either. They tend to remember the stuff that they do the most. And that's just how it is. They don't have to know everything. They can always look it up or talk to another PTA who deals with it more and stuff like that. So just don't feel like you have to know everything, because you don't. You're there to learn and to get better.
Awesome. Thanks.
Kind of piggybacking off that, don't be afraid to ask questions, even if you feel like it's dumb. Ask the questions if you're unsure, because it is better to ask the questions while you're a student now and get the answer rather than when you're licensed and then doing something wrong and that's on you
Yeah.
at that point, and then you're by yourself.
Right.
But ask questions, but also my advice would be, like I said, go in there, be confident, be yourself. Know the things that you need to do, but also don't think that just because you're not in class, your class is over. So like there's been many a times where I've had to come home and, well, crap, I don't remember any of this, so I need to look this up, I need to do a little studying tonight,
Yeah.
I need to refresh on that. Like, don't think that just because you're not in class every day with Miss Martin and Prado and Weatherhead and Rosemary and all them, that you are just gung ho and you're free and you don't have to open up another book ever again. Like, you continue to study. And then my other last piece of advice would be is, Savannah, this doesn't relate to you a lot, but Bryce, stress this to the rest of your cohort. You need to practice what you learned first semester, because your transfers, your gait, your stairs, your things like that, your soft tissue, your draping, those things you will do. Those are the things that you do every single day. And so, like, don't get so caught up in procedures 3 and procedures 4 and all of these things and not be practicing these other things, because that's what's going to hit you in the face when you on your first day, and you're going to be like, oh my God, I don't know. Like, and then you're going to really come home and start cramming because you've forgotten everything from first semester, like me. So just continue to practice those transfers and the gait and the wheelchairs and those type of things. Don't forget that stuff, even though I know procedures 3 is hard and procedures 4 is going to be hard too, but like, don't forget those things.
Yes, Savannah, and that's exactly what y'all are going through right now. I remember. So funny story for me, like the hardest thing for me was to actually tie my gown behind my back. Like I was having so much trouble and my fingers are my skin is so dry and everything. It was like sticking. And I was like, oh my gosh, I can't believe I can't even tie a gown behind my back. So I get like all those. What about Kelsey and Jennifer, either one of y'all?
Yeah, 100% agree with Josh and Kelsey. Like, you're still learning, like you're still in the program. They're gonna help you like fill in the pieces. So it's okay to say, I don't know. I say that a lot. And she's like, that's okay. Like, I'm more than happy to teach you, or like whatever. And so as long as you like try and like critically think, they appreciate that too. They know that like you have that critical thinking process there. But yeah, they're more than happy to help you at any time. So I wouldn't stress about that. And I will say for me, one of the things that I had to learn was you go in and you expect like help everyone, kind of like fix everyone. But with outpatient, we have a lot of workers' comp people. And then some people just want to milk the system. And so for me, that was hard because they would just complain with everything that I did, or like I caused them so much pain, or here they are like years later and they still can't do anything. And you just have to not take it personally. Like, just do the best that you can, and then just document that. And so you're not going to fix everyone, and that's one of the big things that you have to keep in the back of your mind.
Yeah, that kind of takes my mind back to professional interactions last semester with Miss Martin. And I remember we talked a lot about that. She said you're going to encounter that a lot. So what about you, Kelsey?
Going from workers comp, you just have to remember too, like they're getting paid to come to PT, so they don't care. Most of the workers comp patients that I see, so can't speak for Jenny, but the ones that I see are they're just
Some of them
there
are really
because they have
good.
to be there.
Yeah, and some of them don't care. So it
Yeah.
could be 50-50. You never know.
Yeah.
When they're coming in, like an initial eval, it's like, gotta figure it out. Gotta get a feel for
Yeah.
it.
That's true.
Go ahead.
Just to piggyback off of that, there are a lot of times where insurances will be like, well, before we'll give you your total knee surgery because you're having pain, you have to have injections and PT first. So a lot of times you have these patients that like they want the total knee, they know they're coming in because they're only going to be there because their insurance said the only way that we're going to pay for your surgery is if you try PT first. So they're going to come in, they're going to be like, this hurts, blah, blah. You're going to give them an HEP. They're not going to do a single lick of it at home. They're going to come in and they're going to continue to tell you my pain's an 8 out of 10. You ain't doing nothing. I don't feel like I'm getting any better just because their insurance says they have to be there for 6 weeks until they'll pay for a surgery. And so then they're like, okay, and they take your discharge and they walk right to the doctor's office and they say, okay, like this isn't working, so we're going to do the surgery now. And that when you first start out as being a SPTA, you think, I'm going to go out there, I'm going to change everybody, I'm going to fix everyone, we're going to, it's all going to be great. And sometimes there's just, you do your best and there's not, like, you can't help it. Like, they just aren't getting better, and that's just how it is.
Right.
And so don't get your hopes crushed when you have patients that don't get better or you can't help or they don't want to be there.
Right.
That was a hard pill for me to swallow.
So, Kelsey, anything else to add on top?
I think for my advice, 2 points would be don't forget your basics. Like, that's so important. Like, don't forget muscle actions and their insertions and origins and stuff like that, because I find myself a lot of times when doing like soft tissue and stuff like that, it's a patient explaining it hurts here and you're like, well, I wonder why. But then you sit there and explain it. Like, I had to explain to a patient the other day that their gastroc and their hamstrings both cross the knee, and they just didn't understand. They're like, wow, I didn't know I would feel that there and stuff like that. So just don't forget basic stuff, basic information. And kind of like Alicia said about rolling patients over, like Josh and I, like, that's basically our treatment session, is to teach somebody how to roll in bed. Just don't forget how to do that. And another thing is what I would recommend doing, and what I kind of started doing, is writing, like while you're going through class and you come up with these different exercises, is to write them down in a book, because you never know when you might need to go back and look at that. And it might just be something as simple as how to strengthen the quads. You could do short arc quad, long arc quads, like just write that stuff down. So when you get in clinic and you run into a patient that is not progressing the way you want it to, like the way you want them to, and you've tried all the exercises, you have that book to fall back on. Just like right now, I have a patient who is struggling to get external rotation, and it's like, man, what else can I do with them? Like, I wish that I would have written stuff down that we learned in class, like the tricks and trade that Miss Weatherhead teaches you. Like, I would have wished that I would have written that stuff down. But then again, also, like, I've called Miss Weatherhead and said, I have this, this, and this, and this. I don't know what to do about it. How do I fix, like, how do I go about it? Right. So, just kind of like start a journal, start a book of that kind of stuff, of little tricks of the trade on how to do that, the stuff.
And still your CI's tricks. I was gonna say, still them. Like, that's what I've done. There's a few of them. Like, I'll give you a good example real quick. I'm sorry, Jenny, to cut you off.
No.
But you guys will probably like this too. This is one I bet you guys will like, because I know I like it. So working on balance and weight bearing, right? This is a patient that's probably needs to weight bear more or whatever. And this one PT up there they had unilateral upper extremity support, right? So like right hand was on a parallel bar or something, and they were standing on their right leg or standing on their left leg. And we had some bean bags out in front of them, and they're different colors, right? and she would call out a color, and they would have to move their right leg to touch that coloring and then come back. Right. And just keep doing that over and over. And then she'd call out multiple colors. So they'd have to do 2 or 3 before she got back. Right. And that's just like a real, you won't find that in a textbook. Right. It's just something that she kind of made up somewhere along the way that's really good about balance, weight bearing, and it forces the patient to do all that without them thinking about it. You know, it distracts them enough. You know, they're really worried about getting the colors right. And, you know, it's cognitive too. They got to get the colors right. It works on a lot of different things. And I stole that one like that. But that was, I did it the next day with somebody. I was like, that's a great one. I wrote it down and I'll never forget that one. And there's a couple like that. That's just one good example.
Yeah.
I'm stealing that one, Josh.
Yeah, it's good. It's really good. I told her, I was like, that's mine now. That's mine. I'm taking it.
Yeah, still like things that your CI does. Number one, when they have a patient do it and you don't know, you're like a certain stretch or a certain exercise, and you're like, how does that help? Like, do it yourself 100%, because you'll learn better that way, because you'll feel it. So we have this one PT, and he takes a weighted ball, so like the ones that are on the back of the trampoline in the lab. He took the 4-pound weighted ball, and you put it on the wall, and then you literally walk the ball in a circle with your fingers, and you just walk it around the wall. And that, oh my God, you're freaking deltoid, dude. Like, holy crap. And I was like, how did I not? Or the other one that I really love is, instead of, when you have your total knees, instead of doing full stairs, you put, so like, let's just say it's your left leg. You put your left leg up on the stair, then you take your right leg and you step up, and then you step down, and then you step up, and then you step down. And it's making that leg work, but without just like going up and down a flight of stairs. And then you turn around and you keep that left leg on the stair, and then you go down and you come back up, and you go down and you come back up. And it's like, just without them ever moving. And it's like, that is just like, how I would have never thought about that. I would have had them done, they'd have done 12 reps of stairs here, but you know, like, we just went back and forth, back and forth, back and forth, and you just cut the middleman out. And I'm like, so take things from your CI, steal them, and be like, put them in your toolbox, remember them forever, and just continue to, it's great.
Jenny,
and then last thing I'm going to say too is, like, so for my binder, you know how you have to have like all your paperwork and stuff. In that binder, I have like my range of motion in there. I have like other documents that would be helpful. So that kind of stuff, like, you accumulate over time. Like, I have total shoulder protocols because they're hard to remember, and you'll get them all mixed up. And until like you practice it a lot, then you'll remember it. But like all those things, like, I refer back to like weekly, daily. And I even have like my muscle like flashcards too. So it's just accumulating that little stuff that helps you in the long run.
Now, when you with like those, do you use them during treatments, or you're just saying like, that's for me to go back to when I know I'm going to have a total shoulder or something like that? Yeah.
So for us, we'll see, like, I'll know like the patients that I'm going to see for the day, so I can kind of prep on my downtime. It's like, okay, you know, it's in the morning, but this afternoon I have my total shoulder. Let me look at like what week he's at post-op, and what he can do, what he can't do, what we've been doing, and how I can progress it. So that way, like, when I get to his treatment session, I'm not doing the same things or whatever, and I'm still within those protocols to where I'm safe and I won't injure the tissue at all.
Those are big. I just had a guy dislocate his hip. He just had a total hip and broke his femur, you know, near the neck, and he had to get a total hip. And we spent 2 or 3 weeks with this guy getting him better. He was ready to go home, basically. And he kept breaking his precautions. Like, he just wasn't safe. He was breaking the hip flexion past 90 degrees was the main one. And he just kept doing it over and over. No matter what we would do, he'd just break it. He was just stubborn, you know. And when he was walking, everything was fine. He was about to go home. And then he broke it one day, I guess, real bad. And he popped his hip out. And they ended up having to do surgery because he had kind of tore up some stuff on the inside with the implants. Normally they could just pop it back in. He'd probably be all right. But so now he's got to start over.
Wow.
You know, so precautions are big, man, and having them adhere to it. Like, that guy wouldn't matter what we done. Like, we daily, man. I was talking to this guy, heart to heart. It's like, you gotta stick to this, man, or you're gonna have to start all over. I literally told him that the day before he did all this. I was like, you're gonna start all over if you keep breaking this, man. You're gonna have to from day one, you know. But those are important.
Well, look, I know it's been a while, so I greatly appreciate all of you guys coming out. And I mean, I can't even tell you, like, it's so invaluable right now. Um, you've like answered a lot of questions, and I'm sure, you know, the rest of my cohort and Savannah's cohort, I mean, we greatly appreciate y'all taking your time out. And we're proud of y'all guys. Like, y'all are the first ones to go out. So, you know, it's pretty awesome. And appreciate all of y'all and everything. And we may try and do this again next week. I don't know. I'm gonna talk, you know, try and see if we can find maybe a few more of your classmates and get, you know, some other perspectives too. So, but I'm
Yeah,
gonna
thank you so much for sharing your stories.